Bismillah ar-Rahman ar-Rahim. In this lecture, I will talk about diabetes and obesity, although they are separated, but I combined the two files together. So we will start talking about diabetes. One minute, please. Okay. Diabetes could be defined as a heterogeneous group of multifactorial polygenic syndrome. And there are many causes and there are many clinical pictures associated with diabetes. It is characterized by an elevation of fasting blood glucose by a relative or absolute deficiency in insulin. There are two types of diabetes, type 1 and type 2, and these are items to compare between type 1 and type 2. For example, the prevalence of type 1 is less than 10%, while the prevalence of type 2 is more than 90%. Genetics has a significant role in type 2 and a moderate one in type 1. The defect in type 1 is that beta cells are destroyed by autoantibodies or by viruses, and thus there will be no production of insulin. In type 2, there is insulin, but there is an insulin resistance with inability of beta cells to produce enough amounts of insulin. Ketosis is common in type 1, but it is not, or it is rare in type 2. The level of plasma insulin is low or absent in type 1 because of the destruction of the beta cell. And in type 2, it is high or low or absent. It depends. Complications, there will be ketoacidosis in type 1, while in type 2, hyperosmolar hyperglycemia in type 2. Response to oral hypoglycemic, type 1 is unresponsive, while type 2, it responds to these hypoglycemic agents. Concerning treatment, insulin is necessary for treatment of type 1, while type 2, diet, exercise, oral hypoglycemic drugs, insulin sometimes, all of these will help in the treatment of diabetes. Some other factors that reduce the risk: weight reduction, smoking, stop smoking, blood pressure control, treatment of dyslipidemia. All these will reduce the risk of having diabetes. Now let us talk about type 1 diabetes. This figure shows you the gradual destruction of beta cells. As you see in this figure, this is the insulin, and this is time in years. This is the initiation event, virus or other factors that will start to initiate destroying the beta cell. Then there is another phase in which there is a slow of beta cell destruction, and the insulin secretion will start to decrease, and then there is a beta cell completely destroyed, and in this case no insulin will be produced, and all of the symptoms will appear in type 1. One of the symptoms, some of these symptoms are polyuria, polydipsia, and polyphagia. Type 1 is diagnosed by glycosylated hemoglobin. Glycosylated hemoglobin is a hemoglobin that is sugar or glucose is attached to it, and it will stay in red blood cells, and it will measuring the glycosylated hemoglobin will give you about the level of glucose in the previous 3 months because of the age of the red blood cells. Any value above 6.5 milligram per deciliter is a diagnostic value for type 1 diabetes. The normal is less than 5.7. Or if the fasting blood sugar is greater or equal 126 milligrams per deciliter, this is another criteria for diagnosis of diabetes. The normal is 70 to 99. Now, pre-diabetic people will show fasting blood sugar to be in the range of 100 to 125 milligrams per deciliter. Also, one could diagnose diabetes if the random blood sugar is greater than 200 milligrams per deciliter. And what I mean by random blood sugar, it is not fasting. The person is taking his breakfast or the meal or his meal, and glucose could be determined after 1 hour or 2 hours, and that will give us about the level of sugar in the post-absorptive state. These are the metabolic changes in type 1. There is a deficiency, as I mentioned, of insulin, and that will affect liver, muscle, and adipose tissue. One of the features of metabolism in diabetes is the hyperglycemia and ketoacidosis. Hyperglycemia is due to gluconeogenesis and the no uptake of glucose by muscle or adipose tissue. Okay, since muscle adipose tissue glucose uptake depends, it's insulin dependent, so GLUT4 will not be working to take glucose in adipose tissue or in muscle. In liver, it is glucose, it is insulin independent, okay, but glucose enters the liver and it is not phosphorylated, so it will come back into blood, so we will see hyperglycemia. Ketosis or ketone body will be increased because of the lipolysis from the adipose tissue. Okay, fatty acids will be released as well as glycerol. Fatty acids will be oxidized by beta oxidation, and acetyl-CoA will be formed. Some of the acetyl-CoA will be used for oxidation to produce some energy, but the rest will go into ketone bodies and form ketosis. Um, Ketone bodies, as I mentioned previously, it is acetoacetate and beta hydroxybutyrate. Also, we will see hypertriglyceridemia uh, because not all the fatty acids will be oxidized, but some of them will be used for the synthesis of triglyceride, as you see here. Most of them will be oxidized, but some of them will be used for the synthesis of triglyceride, okay, and will be packaged into very low density lipoprotein, okay, and this VLDL will leave the liver to blood to accumulate. Chylomicrons also, which are synthesized in the intestine, they are accumulated, and as a result, we will see a high level of triglyceride in diabetes. Lipoprotein lipases are not working because the insulin is not there, but hormone sensitive lipase is working, that will help in no problem, forget about this part. Okay. Now, treatment of type 1 diabetes. The concept here is that external or exogenous insulin is required because insulin is not found, or the level of insulin is zero in type 1 diabetes. So there are two types of treatment: the standard treatment and the intensive treatment. This represents the mean blood glucose, and this represents the percentage of hemoglobin A1C. In the standard treatment, okay, 1 or 2 daily injections of insulin, the level of glucose is above the normal. This is the normal glucose level. It is about 225 milligrams per deciliter, and still the hemoglobin A1C is about 9. It is high above the normal range. This is the normal. And while in the intensive insulin therapy, the glucose level is less than in the standard, as well as the hemoglobin A1C is less. But still, both did not reach the normal hemoglobin A1C normal, nor the normal of mean blood glucose level. Okay, it was found that 50% or more reduction of complications resulted from the intensive treated patients. These complications are neuropathy, retinopathy, and nephropathy. So 50% of these complications are prevented. Okay, another complication in the intensive therapy is the result of a threefold increase in frequency of hypoglycemia. So this is the hypoglycemic episodes when type 1 diabetes treated with intensive therapy versus the conventional therapy. So the rate of hypoglycemia is very high. Now, these people suffer from deficiency of glucagon, but there is a compensation by epinephrine to prevent the severe hypoglycemia. But unfortunately, because of the impaired ability to secrete epinephrine, okay, in these patients, the hypoglycemia is still there. Okay? Uh, these patients are advised not to do extensive exercise because exercise will promote the glucose uptake into muscles, okay, and that will cause also hypoglycemia. This is all about type 1 diabetes. Now I will talk about type 2 diabetes. Some of the symptoms, طبعا, as I mentioned, there is an insulin resistance in the peripheral tissues, liver, adipose tissue, and muscle. In the liver, there is an increased production of uh, glucose by gluconeogenesis and glycogenolysis, and that glucose which is removed from the liver will be accumulated because there is insulin resistance, so the uptake will be decreased via GLUT4. And also in diabetes type 2, there is not enough insulin as secretion from beta cells. Accordingly, we will see some polyuria, polydipsia, and little polyphagia in these patients. Okay? It was found that a combination of insulin resistance and dysfunctional beta cells will lead to or will result in diabetes. Metabolic alterations are milder in type 2 when compared to type 1. Diagnosis is based on hyperglycemia, depending on the fasting blood sugar and hemoglobin A1C and random blood sugar, and depending on the values of sugar and hemoglobin A1C, as I mentioned in type 1. Okay, because of hyperosmolar hyperglycemia complication, okay, we will see hyperglycemia and dehydration and polyuria and polydipsia because of the hyperosmolar hyperglycemia. Now, when a person in obesity or an obese person, the adipose tissue in obese person will produce different types of factors like adiponectin, some interleukin 6, etc. And these and some inflammatory factors, these will cause insulin resistance. So obesity lead to insulin resistance, and as a result, okay, of insulin resistance in obese people, there will be an increase in lipolysis and decrease in fatty acid oxidation, and as a result, there will be a high level of free fatty acids in the blood. Because of insulin resistance, also gluconeogenesis in liver will be increased, and that will lead to hyperglycemia, and also glucose uptake by muscle and adipose tissue will decrease. All of these will lead to hyperglycemia or an increase in blood glucose. So in obese people, one could see high level of free fatty acids because of these, and high blood glucose because of these factors. Okay. Now it was found that, as you see in the previous slide, obesity causes insulin resistance because the adipose tissue in obese people will produce many different uh, inflammatory factors. Okay, and it was found that most people with obesity and insulin resistance do not develop type 2 diabetes. Why? Because higher insulin levels are required to control blood glucose in insulin resistance obese individuals. So uh, blood insulin will rise, okay, above the normal level after each meal. So these peaks represent the amount of insulin produced versus in obese people versus the normal people. So these high amount of insulin will compensate, okay, for insulin resistance in obese people. And if you see that blood glucose is the same in both obese and normal individuals, because the glucose, okay, in obese people was lowered by high amount of insulin produced in obese people. Okay, this is the stages of diabetes type 2. This is the stage of diagnosis. As you see, obese individuals will develop insulin resistance, which may precede development of diabetes by 10 years. So this is the years of diabetes, about 10 years below development or below diagnosis. Okay, the next step is that the patients diagnosed with type 2 diabetes show insulin resistance with compensatory hyperinsulinemia. So still blood glucose is not too high because of the high insulin level. At this stage, okay, beta cell dysfunctioning will result, and there will be a marked decrease in insulin and a marked increase in glucose level. So this is the stages at which diabetes type 2 will have. Now here to show you how also development of diabetes, it starts with insulin resistance, and there are many reasons of insulin resistance: genetics, obesity, lifestyle, and aging. That will lead to an increase in insulin secretion, hyperinsulinemia, and as a result, there will be a defect in glucose metabolism, and that will lead to decline of beta cell function. And there are also different causes: منها genetics, glucose toxicity, and free fatty acid toxicity, as we see in the previous slide, and that will lead to type 2 diabetes. And these are the complications at these stages of development of diabetes. Now, as I mentioned, obesity will, in obese people, the adipose tissue will secrete different things, an increase in cytokines such as interleukin 6, an increase in leptin, a decrease in adiponectin. This is anti-inflammatory, and adiponectin is known to increase fatty acid oxidation. So because we don't have enough adiponectin, there will be an accumulation of free fatty acids, and that will increase the destruction of beta cells. Okay. Um, uh, Development of insulin resistance as a result of these will increase the lipolysis and the production of free fatty acids. Uh, these free fatty acids, some of them will be oxidized, and that will decrease the oxidation of glucose, and that will lead to hyperglycemia, and also accumulation of free fatty acids will lead to triacylglycerol and in the liver, and that will cause what is called the hepatic steatosis. Free fatty acids also are pro-inflammatory, and they will cause or suppress glucose-induced insulin release. This is the metabolic picture in type 2 diabetes. As you see here, because of the insulin resistance in muscle and adipose tissue, there will be hyperglycemia. And why? Because there is an increase in gluconeogenesis rate. Gluconeogenesis from amino acids that come from the diet. So they will be used to synthesize glucose, okay? And glucose will be transferred from liver to other tissues. Little of pyruvate will go into acetyl-CoA. Most of it will go into glucose formation. Little of acetyl-CoA will enter Krebs cycle. Fatty acids from adipose tissue and lipolysis will be oxidized and be used for synthesis of a triglyceride. Will be oxidized, not synthesized, to acetyl-CoA to make ketone bodies, and will be used, some of them, for synthesis and forming the VLDL. So there will be an accumulation of lipids, VLDL, chylomicrons, as well as hyperglycemia. Little ketosis is present here because of the presence of some of the insulin. Comparable to type 1 diabetes, absence of insulin causes a lot of ketone body formation. Okay. So in diabetes, type 2, we will see hyperglycemia, dyslipidemia, and what I mean by that, increase in the VLDL, increase in chylomicron, and decrease in high-density lipoprotein. Treatment. The goal of treatment is to maintain blood glucose concentration within the limits, okay, from 70 to 99 milligrams per deciliter. These are some ways for decreasing risk of diabetes type 2: weight reduction, exercise, and diet. And some people are taking hypoglycemic agents, metformin, that will inhibit gluconeogenesis, sulfonylureas, increase insulin resistance, secretion, and the thiazolidinodines increase the insulin sensitivity and inhibit alpha glucosidases that will decrease the absorption of glucose, or sometimes some people are taking insulin therapy. This is the following up of um, diabetes, okay, uh, at various levels of hemoglobin A1C and the probability of leading to retinopathy. So when glucose is controlled, hemoglobin A1C, when it is 7%, little bit above the normal, the prevalence of retinopathy is very low, comparable to these values of hemoglobin A1C because of the uncontrolled glucose and untreated. So controlled and treated glucose will reduce the probability of retinopathy. How we follow up uh, and follow up the level of glucose by measuring the hemoglobin A1C every time and trying to keep it as low as uh, possible, close to the normal, to reduce the probability of having complications like retinopathy. This is to show you the effect of exercise and body weight, okay, on the incidence of type 2 diabetes. So, in people who are not obese, healthy people, okay, the risk of the incidence of diabetes is very low. In people who have body mass index from 24 to 25.9 has higher uh, incidence of diabetes, and obese people who have body mass index greater than 26, okay, will have higher probability of having retinopathy. Exercise will do some decrease, but still it is high risk of having diabetes in obese people. Now, this is for this is all for diabetes, and I will start talking about the obesity. Obesity means an accumulation of excess body fat, and obesity is measured by taking the size of waist and measure the amounts of fat in central abdomen area of the body. Normally, the waist size in men is equal or greater than 101.6 centimeters, and in women, okay, is not, oh, I think this is wrong. Equal or less than 101.6 and equal or less than 88.9 centimeters. Now, body mass index is defined as or calculated as the weight in kilogram divided by the square height in meters. So supposedly one person is weighing 70 kilograms, take its height 1.7 meters, square them, divide the weight on the squared height in meters, you will get what is called the body mass index. This chart correlates the weight in pounds with the height in feet, and this is the amount, the values of the body mass index, okay, between, this is less than 18.5, this is between 18.5 and 25. This is for healthy people or healthy weight, not obese. People who having body mass index between 25 and 30, they are considered as overweight, and people who have more body mass index more than 30, they are considered as obese people. Obesity depends on the accumulation of lipids. Accumulation of lipids could be in the upper region or could be in the lower region. Upper region has high risk of different diseases of obesity than the lower lipid distribution in the body. The lipids could be subcutaneous and visceral, okay? And the abdominal lipids are more dangerous than the lower. Why? Because the upper lipids, when lipolysis takes place, they will go directly to the liver, while in this case, upon lipolysis, they will be distributed and this amount will go to liver. Okay? These are some of the biochemical differences in regional fat deposits, سواء كانت abdominal, okay, or كانت in the hip region. As I mentioned, lipids in abdominal or it is subcutaneous and visceral. The visceral adipocytes will produce, they are very active and produce different inflammatory factors. Okay. Subcutaneous and visceral fat from obese individuals have high rate of lipolysis and high free fatty acids. Upper body obese have higher risk because of the metabolic difference. As I mentioned, adipocytes will produce different factors, protein regulators, such as leptin and adiponectin hormones. Leptin is important because it regulates the appetite and metabolism, okay? And leptin level will increase as the body weight increase, okay? And if the body weight decrease, leptin level is lower. Adiponectin is very important. It reduces free fatty acids that cause insulin resistance, and they are considered as inflammatory factors or pro-inflammatory factors. Adiponectin helps to improve lipid profile in terms of triglyceride, LDL and VLDL levels, normalize them. It increases insulin sensitivity and it reduces inflammation in diabetes. And adiponectin decreases as body weight increases. So keep the body weight low in order to have high amount of adiponectin to avoid diabetes. Free fatty acids and cytokines released from upper subcutaneous and visceral, as I mentioned, they enter the portal vein directly to the liver and lead to insulin resistance and increase hepatic triglyceride, VLDL, and hypertriglyceridemia, comparable to the lower subcutaneous lipids. Okay. Now, this is to show you that the obesity is due to combination in the increase of adipocytes as well as in the number of adipocytes. So, Um, this is how the obesity is affected, as I mentioned, by the number, by the size and the number. When weight is lost, okay, the number is remain the same, but the size will decrease. When there is a gain in weight, the number and the size of adipocytes will be increased. Okay, there are genetic factors that are play in obesity. These are identical twins, and both of them are obese. Okay, adopted children show differences in body weight. Okay, although they are exposed to the same environmental factors. Also, mutation in leptin gene will cause some disturbance in controlling the food intake, as we will see it later. So this person has a mutation in leptin, so she is obese, while this person has a normal leptin gene, not obese. So most obese humans have elevated leptin levels, but appear to be resistant to appetite regulating effects of this hormone. And we will see these effects in a minute. Now, in people who are undernourished, okay, there is an increase, there is a leptin will, leptin level will be secreted, and it will control centers in the brain, and the brain will send signals, okay, to increase the appetite and to decrease the energy expenditure. Okay, so this is the case, this is the effect of leptin in undernourished people, okay, how it affects the food intake. So it will increase the appetite, increase the food uptake, and at the same time decrease expenditure of energy. Okay. The same thing when the person is obese or overnourished, the amount of adipocyte or adipose tissue is very high. So there is a high level of leptin secreted, binding or signaling some centers in the brain, and these centers will send signals to decrease appetite and increase energy expenditure, as you see here. So this is how leptin in these two cases affect the appetite. In this case, it increases the appetite because of the undernourished, and here it decreases the appetite because of the overnourished. Okay? In obese people, leptin sometimes this leptin does not work as I explained here. There's another hormone called ghrelin, okay, and it is a signal for hunger in undernourished. Its secretion or concentration is increased, and is, binds to some centers in the brain. Brain will send some signals to increase the appetite and decrease energy expenditure. While in the overnourished, okay, ghrelin is low, and as a result, it will decrease appetite and increase energy usage, as you see here. What are the metabolic changes in obesity? There is what is called the metabolic syndrome. Metabolic syndrome, these are characteristics of it: glucose intolerance or diabetes, hyperglycemia, insulin resistance, hyperinsulinemia, dyslipidemia, low HDL, high triglyceride, high LDL, and hypertension. Another metabolic change in obesity: chronic systemic inflammation, atherosclerosis. Also, in this condition, okay, there is a release of pro-inflammatory factors such as interleukin 6, and also there is a low level of adiponectin, and we saw in the previous slide what are the importance of adiponectins. Okay, go and reread them. And also, this is to show you the relationship between obesity or body mass index versus the concentrations of these lipid components. As you see, the total cholesterol is increased as the body mass index is increased. The triglyceride is increased as the body mass index increased. HDL is decreasing. HDL is the good cholesterol that collects the cholesterol from the tissue and send it to the liver for other metabolism. Triglyceride and total cholesterol, they are harmful to the body when they are accumulated. Okay, so body mass index or obesity resulted in these things also. I think this is the end of this lecture. I hope you are good luck in your exams and wish you the best.